Okay. So this is our second PowerPoint presentation on extremity veins. We're going to discuss non-invasive imaging. So this is going to be our duplex imaging. So I'm just going to try and go through as much of this as I can. So venous duplex. This over here. So I'm looking at you guys. Yeah. Boom. There we go. Share down. All right. So venous duplex. Why do we do our ultrasound exams, our DVT studies? So we have three main reasons. First and foremost is to determine the presence or absence of thrombus. So we're looking for clot within the veins, looking for the presence of DVT or superficial thrombophlebitis, the superficial clots. Part of that exam, we can determine the relative risk of that clot, potentially dislodging and then traveling to the lungs, becoming a pulmonary embolus. And then the other main thing that we look at when we're doing a venous duplex exam is for valvular competence. So we're looking for leaky valves, reflux study. So really that's the two main things. I mean, we could also potentially get into vein mapping that we're going to discuss as well. So measuring the diameter of those veins, the depth of the veins for potential use for hemodialysis access grafts, as well as, potentially harvesting that great saphenous vein for bypass, for either arterial bypass or for coronary artery bypass. But for really the main reason for us doing these duplex exams are first and foremost ruling out the presence of thrombus and then assessing for valvular competence. We'll discuss a little bit the imaging characteristics of normal veins, Doppler characteristics of normal veins, and then we'll start talking about thrombus within the vessels, acute versus chronic, and if we get that far into instrumentation and the imaging protocols for the upper and lower extremities. So thrombosis and thrombolysis. So thrombosis is the formation of clot, within the vessel. Thrombolysis is the breaking down of clot within that vessel. So a thrombus, as a clot starts to form within the vessel, this actually will induce or cause additional clot formation. So clots get worse, as it starts to develop. That formation of that clot, again, makes a nice surface for additional clot to build on. So it starts to form on that original thrombus, and the thrombus grows. And that growing or that expansion of that thrombus, we refer to that as propagation. So it's not that the clot is actually, like developing, say, in the popliteal vein and then moving up the leg. That clot is actually expanding, it's growing. So that growth of that clot, we refer to that as propagation. So it propagates proximally. That's what we worry about. That clot starting in the calf veins and then propagating and growing into the popliteal, and then from the popliteal into the femoral vein into common femoral into external iliac, common iliacs, IVC, it can go all the way up. Just keep in mind, thrombus formation is also an inflammatory response. So that's not normal. That's not a natural thing that's going on inside that vein. So the body's trying to attack it, trying to break it down. So when the body's trying to attack something that's, not normal, that shouldn't be happening, there's a natural inflammatory response that occurs. So that's why we wind up with the phlebitis part. So we get inflammation of the vessel walls as part of the a DVT. Plasminogen is an enzyme that will chemically break down clots. So it lyses and breaks down clots. And as that clot breaks down, so as it goes through the process, so we go through the process, the clot formation, the acute phases, and then as the body's trying to break it down, and break down that clot, it enters into that chronic phase where the residual thrombus, any residual thrombus that does not break down, gets invaded by fibroblasts and becomes fibrous scar tissue. So that plaque forms these fibrous scars on the inside of the vessels that we could see on ultrasound. So this was just showing, normal up here at the top, artery and vein. And then when we compress, the vein should compress all the way down. So it should be even more than that. You should see no vessel at all when you push all the way down. Showing nice color flow pictures, normal venous signal with respiratory variations. Again, just keep in mind, clots can be partially occlusive. So that's what you're seeing here. So we have a partially occlusive thrombus. So there is some flow still getting through that vessel, but there's an area where flow is not, where that thrombus exists. Again, those clots would be partially compressible, and we can still get a Doppler tracing because there is still some flow getting through that vessel. I know this looks a little strange here, but this is supposed to represent a completely occluded vessel. So again, when the vessel now is completely thrombosed or fully thrombosed, it expands, it dilates in size. If it's fully thrombosed and there's no flow getting through and there's absent flow, it's completely non-compressible, or we just say non-compressible, whereas the one above it would be partially compressible. And then when we Doppler that vessel, there's no flow, so no flow is evident. We don't get a Doppler tracing because there's no flow. It's completely occluded or completely thrombosed. And then on color flow, there'd be absence of color, within that vessel. The normal veins should be echo-free, so they should be anechoic without echoes. The wall should be thin and smooth. We may see the valves, depending on the patient's body habit is, how deep that vessel is, how clear of an image we get. We could potentially visualize those valves clearly within the vessels. Compressibility. So again, when there's thrombus within that vessel, it doesn't coap. So that word coap is what we use to describe the compression of the vessel. So when a vessel fully coaps, it fully compresses down. We do compression in a transverse view. So you guys might be in the text and the sites, or in sagittal, you might be trying to compress on a vein. So when we acquire those compression images, we're only doing those in transverse view. So we only compress in a transverse view. Again, that compression technique is our primary criteria for diagnosing the presence of DVT. So we have to perform that compression maneuver in order to definitively rule out DVT or to definitively make the diagnosis of a positive DVT. We have to perform that compression maneuver and demonstrate partial compressibility or non-compressibility. We talked about vein size. So the veins of the arm and the thigh are larger. So the upper arm and the thigh are larger than those corresponding arteries. Vein size may increase. So the proximal veins are much larger than the corresponding arteries. The vein size may increase because of back pressure. So we can have venous hypertension that could lead to increased vein size, also congestive heart failure, or even fluid overload. So if we've, really overly hydrated this patient, this would lead to dilated vein size. And then we talked about venous congestion. So things that can cause venous congestion, maybe a proximal clot, proximal compression of the vessel, lead to venous congestion and dilatation of those vessels. Veins may appear very small on the flip side of that if the patient is, severely dehydrated. Maybe they're hypovolemic, they have very low blood volume, or they're just severely vasoconstricted. Maybe they're super cold or nervous. So we discussed also a little previously about, flow patterns. So venous flow patterns in the arms and the legs as it relates to inspiration and expiration. So again, that diaphragm moving up and down, changing the pressures in the thoracic cavity and the abdominal cavity leads to changes in flow patterns with our venous flow in our upper and lower extremities. So this is, what creates that nice rhythmic pattern that we see on our Doppler waveforms. So that phasicity, so those changes of the phases, cycles of the moon, the in and out, the ebbs and the flows are all caused by our breathing, our inspiration, and the movement of that diaphragm up and down. So when you have to figure out these questions about, upper extremity flow and lower extremity flow with inspiration and expiration, again, just visualize what that diaphragm is doing during inspiration and expiration. So when you breathe in, deep breath in, that diaphragm, as the lungs are filling, the diaphragm's going down. So that's going to squeeze those abdominal, organs, create high pressure in the abdominal cavity. So with high pressure, that's going to impede flow. Blood flow doesn't want to run into high pressure, it wants to go downhill, it wants to go towards low pressure. So with that deep breath in, you have high pressure in the abdominal cavity. That's going to decrease here your lower extremity flow. But on the flip side of that, it's going to create low pressure in the thoracic cavity and then increase flow in the arm. So the blood flow in the arms is going towards that low pressure. So increases flow. So then just flip it with expiration now. Expiration, diaphragm going up. So now you have higher pressure because it's squeezing the lungs, higher thoracic pressure. That's going to decrease the upper extremity flow. But now you have nice lower pressure environment in the abdominal cavity. That's going to promote flow coming up the legs. So it's going to increase lower extremity flow. And then Valsalva, we're increasing both abdominal and thoracic pressures at the same time. So that decreases or eliminates flow in both the arms and the legs simultaneously with Valsalva maneuver. So again, the veins should be nice and echo-free, have thin walls. When we put our color flow picture on, the vessel should fill completely with color. So something to be aware of. We can have intraluminal echoes when the patients have very slow velocity flow within the veins. So very slow, sluggish, stagnant flow. So this is called Raylos flow or Raylos formation. So this could be caused by several different factors. Maybe the patient has venous congestion, caused by maybe a proximal clot blocking that blood flow. Maybe something's compressing the vessel higher up, causing that sluggish flow. Maybe it's due to, inactivity or immobility. Maybe they've just got poor circulation in that point, leading to this stagnant flow. So that's why this, compression technique is very, very important. If you were to just look at this 2D picture and then put color on and your color flow or your color Doppler settings are set up where your scale is too high and you put your color on and there's no color filling, you can say, oh my God, this looks like a clot, what's going on? But when you turn and compress on it, the vessel compresses all the way down and you actually squeeze out this slow flow. So also keep in mind, if you see this very sluggish flow, this could potentially be a precursor to the development of clots. I always like to tell the story. I had a woman who was like, later on in her pregnancy, I think she had twins, to be honest. So she was like 30-something weeks, like getting towards the end of her pregnancy. Came in, legs very, very swollen, very, very swollen, painful. I did the DVT study and, she had this Raylos flow, this very slow, stagnant flow. And I could see the blood flow just kind of smoking and swirling and but it was negative. Everything was able to compress, even though it took a lot of pressure to compress those veins. But I mentioned it to the doctor, she's got this Raylos formation, this slow flow. And she, maybe you should tell the doctor about this. Maybe she needs to go on some sort of, anticoagulation temporarily, while she gets to the end of her pregnancy. It's probably due to those twins pushing on the IVC, pushing on the iliacs, compressing the vessels, causing this. They just read it out as negative, didn't mention anything about this, to the doctors. And then she comes back a week later, both legs completely thrombosed, DVT up and down both legs. And I'm just like, oh God, and I was the one who did her follow-up scan, and it was just a little frustrating at that point, what's going on. You share that, with the doctors, and then they don't heed your advice, as a sonographer. But so this was showing again normal valve now, and then again we getting some intraluminal echoes because of the stasis of that blood. So we said the valves exist within a sinus, so the vein will dilate slightly in the area of those valves, and this is that valve sinus where the valve is attached to. And we said that, when that valve closes, particularly, a patient standing, the valve closes and blood flow's coming back, the valve is preventing that blood flow from coming back. That valve area of the valve sinus over here, and here makes it a nice little pocket for blood to collect and could potentially form into clots within that valve sinus. This is a good example of when, if you push on the vessel at that point, you might be able to actually, we call it milking out or squeeze out, some of that stagnant blood that's sitting in that sinus. So it may look like a clot, but when in actuality, when you push on that, It's just stagnant blood that's sitting in there that hasn't actually clotted yet. Again, compressibility is what we look for, to determine the presence or absence of DVT. So again, normal compression, it should compress all the way down. So it should be further than this completely. You should see no area of the vein left when you're during normal compression. So it's a good example. So compression demonstrates a vein-free, thrombus-free vein. So this is now level of the common femoral vein. Ooh, with at the saphenofemoral junction. So this is great saphenous connecting into your common femoral. So in this case, we see SFA, DFA. So the common femoral artery is already bifurcated at this point. And then when we push down, that vein compresses completely down and we're left with just the arteries there. So this was another image. So on 2D, we see some intraluminal echoes in here. So it looks like something might be going on here in this vessel. Not quite sure. So here we're in the left leg because the vein is medial. Arteries are lateral here. So we know we're in the patient's left leg. And when we compress down, the vein completely compresses down. We're left with just the artery. Left with just the artery. So we know that that was just a fake out. Maybe this was just artifact. And there's no DVT. Versus a patient that actually does have a thrombus, in the vessel now. So same thing. Now we're in common femoral vein. You could see large common femoral vein dilated. We see again now our intraluminal echoes, but these look a little more spongy in nature. We got some mixed exogenicities within it, some little echogenic areas, more hypoechoic or anechoic areas. This would be another example of acute DVT. Oh, sorry. In this case, with and without compression. So with compression, without compression, you could see obviously this vessel does not compress. Got some intraluminal echoes. So this is again a nice example of a acute DVT here. So when we're doing compressions, you have to just be careful of false positive results. Make sure that you do apply enough pressure to completely coapt that vein, compress it all the way down. Particularly when we're in the groin, when we're doing the common femoral, there's the inguinal ligament there. So sometimes it can be a little bit tricky, a little bit difficult to compress fully the vessel, particularly if the patient is in a good deal of pain. They're going to be fighting back, pushing back on you, so it might make it a little more challenging. We'll work on some techniques. Sometimes you maybe have to do like a little scooping maneuver to really get it to compress. Maybe you might have to come a little bit above and kind of push down. So we'll work on some techniques to ensure that you don't, you're not giving a false positive result here. So it's just showing a nice longitudinal, femoral vein. So you can see that artery anterior to the vein there. That vein filling nice, completely with color all the way across. So that's a nice, beautiful color image. And then when we Doppler, when we start doing the legs, we're gonna work on augmenting the vessel as well. So reaching back, trying to squeeze the calf, performing augmentation. So again, you could see nice respiratory variation and then our nice augmentation here. That demonstrates that phasicity and distal augmentation. So this is a normal venous response. This is what we're going to try and be doing for our lower extremity DVT study. So this is now working our way further down the leg. We have femoral vein and femoral artery. So again, showing with and without compression. So this is what it should look like, that vein completely coapting and compressing down. So just keep in mind, again, we talked about patients who have anatomical variants or collateral vessels or duplicated vessels. So in this case, we're at the common femoral level, seeing artery and vein. And this patient has collaterals or a duplicated femoral vein where one of them compresses and the other does not. So here we could see superficial femoral artery, deep femoral artery, and they have duplicated vessels with that deep femoral artery. And the same thing, one of the vessels partially compresses, the other one also partially compresses. So there's a little something going on in both of these. And this one, this vessel does not compress, this one does. So out of all those vessels, really, this is the only one that is completely patent. And there's thrombus located or present in all the other ones. So whether it's acute or chronic, that's up to us to try and figure out, or the doctors to look at any previous. Now this is getting down into the calf veins now. So here we could see large dilated posterior tibial veins paired with the posterior tibial artery. And you can see they're quite large, quite dilated compared to that artery because they are filled with thrombus. There's no flow, color flow present within that vessel. And then if we were to do a compression picture, I'm sure that these would be non-compressible. So Valsalva maneuver. So Valsalva maneuver will actually dilate the vessels. So again, if you're having a hard time trying to visualize or see a vessel, you can have the patient potentially Valsalva, see if that causes the vessel to dilate a little bit for you to be able to visualize it. And then if the vein truly is thrombosed, there will be no changes in diameter if it's clotted. So Valsalva maneuver isn't going to affect anything. And that vessel's thrombosis, so it's not going to change in size, with respiratory change. There will be no respiratory changes once it's thrombosed. So normal Doppler characteristics. So these are some terms that we use to describe, venous flow. So normal venous flow should be spontaneous, meaning the flow should just kind of flow on its own, so it should just be that nice, steady flow that we can pick up with color and Doppler, and it follows, our respiratory breathing, our respiratory variations. So spontaneous flow is flow that just happens on its own. So spontaneous flow should occur in our central vessels, our more proximal vessels. But something to just keep in mind, the further you get away from the heart, further away you get away from the diaphragm, from the lungs, the less spontaneous flow you have. So that flow starts to slow down, particularly in elderly patients. So as they age, you'll notice that they have much less spontaneous flows, particularly when you start getting down into the smaller calf vessels. Or further distal down the arm. So you guys might have noticed that when we were scanning here in lab, some of the patients or some of you guys, when you got further away, you had much less spontaneous flow, and it makes it much harder to image. So that's one thing that you're going to document or notice. Phasicity, we know, so that's the respiratory phases for inspiration, expiration. So these are low velocity flow changes due in response to respiration and cardiac pulsations. Valsalva response. So again, we know that we have the patient's Valsalva. This should be an abrupt cessation or diminish flow volume, diminish velocities. Again, we can utilize that to determine the patency of vessels if they dilate during Valsalva maneuver. And then augmentation. So this is something that we do, a lot during our venous studies. If we need to elicit flow within a vessel, you can reach down and augment distally to try and, show flow and patency of the vessel. So I'll utilize augmentation just to get that nice color picture with the vessel fill in with color to show the doctor, like, even though I'm not getting the best spontaneous flow, the vessel is still patent. I showed them the compression pictures. When they want to see that color picture, I'll augment just to show the vessel fill with color, to prove to them that there is no thrombus in there with our color picture as well. And then when we're doing our lower extremity duplex study, that is part of most hospital standard protocol when you're imaging the veins for the legs to do a distal augmentation and show that augmentation response. So we can utilize augmentation to prove to the doctor that there is no clot between the area, that we're augmenting and when we're imaging. So just kind of zoom out here. So if I'm imaging, femoral vein, proximal up here, I got my probe there, I'm getting my Doppler tracing. If I augment, down here at the calf, which was what we should be doing, we're going to be training to do, when we do distal augmentation, I squeeze the calf here and I get an augmentation response. I see that spike of blood, that surge of blood. That's for me to prove to the doctor that, hey, when I augment here, there's no occluded or occlusive clot that's blocking the vein and preventing that blood flow from, surging forward. So if, the patient does have a thrombus, say, in the popliteal, that's completely occluding the popliteal. When I augment here, I'm not going to get a response because that blood flow isn't being, pushed forward. So with that augmentation, it's pushing that column of blood upwards, creating that augmentation response. So if I have a clot occluding the vessel anywhere along that path, I'm not going to get that augmentation response, or a very minimal augmentation response. But if the vessel is completely patent and clear, when I augment, I should see a nice surge of blood, coming back up towards the heart, and actually get that very strong augmentation response. Something that you might also, be aware of while you're doing a DVT study is the direction of blood flow. So again, if reflux is present, you'll see that vessel turn from red to blue, when it should just, again, those valves should be keeping blood flow moving in one direction. So it all should just be blue. We're just showing you again, phasicity, spontaneous flow. So that phasic flow following our inspiration, expiration versus a continuous flow pattern where it's just, essentially flat, hugging the baseline, very low velocity. Here we just see good examples of normal spontaneous phasic flow here in the common femoral. And normal respiratory variations. So again, the closer you get to the heart, the more pulsatility you'll get. The further away from the heart you are, the less pulsatility you'll get. So, particularly when we're talking about subclavian and innominate, IJ, jugular vein. So those are in very close proximity to the heart. We'll get a lot of cardiac pulsatility to those vessels. So it's less common to see pulsatility when you get into the legs. But if you do see pulsatility, when you're doing your lower extremity DVT studies, that could potentially indicate a patient who has congestive heart failure, or CHF, or some sort of right heart pathology like tricuspid regurgitation. So when I start seeing very pulsatile flow in the common femoral veins, to me that will indicate a patient who has congestive heart failure. So we're seeing what almost looks like arterial flow. So you could see cardiac pulsations. It's following a rhythm of the patient's heart in addition to their breathing. And then this is a good example of that, continuous flow. So very flat, no respiratory variations, hugging that baseline, very slow flow. Again, that indicates either venous obstruction, so a clot obstructing the vessel, or external or extrinsic. So that's the other word I like to use. Extrinsic, meaning from the outside, extrinsic compression. Something's compressing that vessel from the outside and causing that continuous flow pattern. So Valsalva maneuver. So this is just showing, your flow, following your breathing, your Valsalva. So it should just be absent, they representing that here just by putting it down at the baseline. So there's no flow during Valsalva. And then when the patient releases Valsalva and that blood flow starts to go again, you actually get a little spike. So you get a little bit of augmentation of flow just after Valsalva as they release and then return back to the normal flow pattern. So you can just see Valsalva response, stops, and then they release. And you get a little bit of augmentation, and return back to your flow pattern. So again, augmentation. So we talked a little bit about augmentation again. So I wish this was kind of flipped the other way around, because that's the way I always see it in my eyes. So take this picture in your mind, just flip it upside down. So this is now below the baseline. I like to keep my venous stuff below the baseline. So we have our normal flow pattern. And then when we augment or squeeze the calf distally, we expect to see a nice surge of blood going back up the leg, and that's represented by this spike in velocity. Again, if there's no augmentation response, that could potentially indicate that this patient has an occluded vein somewhere in between where you're augmenting and where you're imaging. There we can see normal venous flow pattern with distal augmentation. So we get that surge of blood coming back up. We see that spike and then return back to your normal flow pattern. Get another example. of augmentation of a vessel. So here we're at the right popliteal, and it demonstrates a good strong augmentation response. So unidirectional flow and venous reflux. So when we get into talking about insufficiency exams and reflux, the Valsalva maneuver is one of the things that we can do or utilize to elicit reflux, to test the patient for the presence of reflux, for leaky valves, incompetent valves that don't hold and cause blood flow to go retrograde back down the leg. So during that Valsalva maneuver, blood flow should just stop within the vessel. So it should just, be absence of flow. There should be nothing there. But if we have valves that are leaky or incompetent, when the patient Valsalvas, we see blood flow going in the wrong direction. So this down here represents, blood flow going back up the leg towards the heart. This represents blood flow going in the opposite direction back down the leg. So it's above the baseline. We're seeing this flow during Valsalva. And then this is the release of Valsalva. So this would be an example of a patient that has, significant reflux in that segment of vessel and leaky valves that are causing, or incompetent valves causing that reflux. When we get into reflux studies, we'll discuss, what's significant, what's insignificant. But basically we're measuring the amount of time that this reflux is occurring for. So down here we have second markers. So this is 1 second, 2 second, 3 second, 4 second, 5 second, So we'll learn that anything over 1 second is considered significant. So in this is, obviously more than 1 second. So this is definitely considered, significant reflux. Little chart just talking about some of the, sonographic features for normal veins. We had mentioned a little bit about, clinical pretest for probability of DVT. Basically anyone who has any sort of symptom, they're going to be getting a lower extremity duplex. Like hospitals don't play around anymore. Doctors' offices don't play around. They don't go, oh, they'll only send them if they have a high probability of DVT, with like 3 points on here. If there's any sort of swelling, they're going to be sending the patient. If there's any sort of pain, they're going to be sending the patient, So acute versus chronic. So we touched a little bit, I think, on this last week. But acute thrombus, it's going to be faintly echogenic, more hypoechoic. If it's very, very new, it could be very, very anechoic and very hard to see on ultrasound. These acute thrombuses are poorly attached. So they're not, they can even be potentially like free floating, moving around, flapping around in the vessel. We refer to them as having a more spongy echo texture. They cause the veins to dilate, particularly when it's totally obstructed or completely occluded. And then acute thrombus are way more likely to embolize, break off, and then travel, to the lungs, form a pulmonary embolism than chronic DVTs. So this was showing a very anechoic thrombus, on 2D. And then when they put the color Doppler on, it became very evident that there was a large, clot existing within this vessel that was partially occlusive. So there's still some flow getting through that vessel. An example of some free floating thrombus here. So even though this is looks more echogenic, this is still considered an acute thrombus. The borders are very smooth with this thrombus. It's loosely attached, so this would be something that you'd probably see visualizing kind of flapping around in there in real time if we're imaging this. Again, some more potentially mobile thrombus. So again, this has mixed exogenicities within it, so we see some areas that are a little bit brighter, a little more hyperechoic, some more hypoechoic and anechoic areas. Be a large acute DVT. So in this, there's no flow getting through. So this is a completely occluded or completely occlusive DVT. Patient's common femoral. And some more examples of acute thrombus. So these are very hypoechoic again. So these are probably very, very fresh, very, very new. Again, the vein becomes very distended when it's completely occluded like this. In this case, there it looks like there's still a little bit of flow trying to get through that GSV. So there is, like I said, patients develop these acute DVT. So DVT is an acute process. When it's new and it forms, it's an acute process, So DVTs are an acute thing. Not something that builds up, takes months or years to develop. DVTs can occur very suddenly. So they are considered acute pathology. After they form, the body again is trying to break it down. It can enter into what's called a more subacute phase. I mean, this is a term that's not commonly used, but could represent a period from weeks to perhaps even 6 months after that initial thrombosis, where there's increased echogenicity. The vein starts, we see decrease in the amount of thrombus, so it's starting to lyse, the body's starting to break it down. And we also see a decrease or shrinkage of that vein. The thrombus can be adhered to the walls. There's resumption of flow. So if it was completely occluded previously, this is the phase where the vessel's starting to recanalize. We're starting to get flow now to return back into that vessel. So there's resumption of flow, even though it may not be the entire vessel that fills with flow. There's some flow now returning to that vessel. We might see thickened walls, and then reduction in the caliber of that vessel. In this subacute phase, we also can see collateral vessels that develop around it. So we might see collateral channels or collateral veins that open up, trying to get blood flow around that initial occluded main vessel. So labs often recommend using terms like recently formed thrombus rather than acute when we want to describe this phase. So in this case, we see thrombosis, patient with a duplicated femoral vein, with one that has a 2-month thrombus in it. The other is patent here. This was a superficial vein that was thrombosed with a patent perforator connecting the deep vein that's down here. So here we can see that again, that acute thrombus is starting to recanalize. So, maybe previous imaging showed no flow in the vein, and now we're demonstrating a little bit of flow now that's starting to get through, and we could still see the thrombus, the residual, acute thrombus still within that vessel. So then now getting into, chronic thrombus. So this chronic thrombus is sequela or a result of, venous thrombosis, often referred to as chronic venous scarring. So in the time period, we're talking about, months to years after that initial, thrombosis occurred, or the initial acute episode. Chronic thrombuses are brightly echogenic. I'm talking very brightly echogenic. So these thrombuses are also well attached. So they're either, well attached or fixed to the wall. If you see them running through that central vessel, just remember you're looking kind of at a 3-dimensional plane. So we might not perceive that attachment sites, but these chronic thrombi look like, to me, sometimes they look like webs or scarring within that wall of along the walls of the vessel. Again, they're well attached, so they're not going to move around. They're not going to be free floating or flapping around. When there's chronic thrombus involved, they typically contract the vessel, causing it to kind of be shrinked or smaller, or significantly smaller than the normal vessel. Because that main vessel is contracted and shrink, these patients with chronic thrombus typically develop larger collateral vessels. So when the thrombus is in its acute phase, the patient might have smaller collateral vessels surrounding it, trying to get blood flow around it. But as it enters into that chronic phase, those collateral channels are the ones that try and take over and support or offer more support, and they become larger in size. So we see larger collaterals in patients with chronic DVT. So we might see thickened walls, that fibrous cord, their fibrous stranding. Because, this chronic DVT scars the inside of the vessels, it also damages valves. So it can damage the leaflets of the valves, preventing them from closing properly, leading to reflux and insufficiency. So with that, we can see Doppler abnormalities. We see the presence of reflux. We'll see lack of spontaneous flow, lack of phasicity within these vessels, abnormal responses to Valsalva or augmentation. So I'm not too big of a fan of this picture as representing chronic thrombi. So for me, chronic thrombi it's really more echogenic. So like this, these are more chronic thrombi. So you see very bright echogenic, but there's flow now getting through that vessel. It's recanalized. So this is that fibrous scarring, fibrotic scarring. Here we can see it along the vessel wall here, brightly echogenic. These fibrotic scars, can become calcified, that they're so hard now that they're calcified. And when things are calcified, they cause posterior shadowing. So this example of chronic clot that's become calcified, that's actually causing shadowing now within this vessel. So here's that thin linear strands. So I think of them like web-like strands that are very bright, echogenic, linear stranding within that vessel. So this represents this cord-like stranding or strings within the vessel, representing chronic scarring or chronic thrombi. Oh, sorry. So here we can see the artery, the vein. Again, it's constricted, smaller in diameter because of that chronic scarring. We could see, again, very bright linear echogenic lines within it, some flow getting through. Here we can see a long, thin, linear echogenic line going across the vessel here, representing that chronic DVT. And some more chronic DVT. So this is a beautiful example here of a chronic DVT. So you see a long, thin, linear fibrotic scar within inside that vessel. So I've seen them, right down the middle. It looks like what is right down the middle of your vessel here, adhered to the walls. You can see a little echogenic part over here. Transverse, you could see that scarring coming across the vessel. So it almost looks like, a dissection. If we were talking about the artery, if this was an artery, I would say, hey, that's a dissection, but we know that this is a vein, that represents that linear scar. So this is what it looks like here in transverse. We see it affixed to the wall here, extending across. So if you imagine, it's kind of this thin, flat thing going across now, and we're slicing it this way, and we can see it coming through the middle of that vessel. So again, we can see chronically scarred chronic DVT within the vessel again becoming contracted up here. You see recanalization of flow. So there's flow getting through these, segments that have chronic DVT. Just the flow is diminished now. And more examples of chronic DVT. So here's bright echogenic adhered to the wall. Again, some wall thickening as a result of that chronic DVT. So this is now showing instead of chronic, partially occlusive acute DVT. So again, just remember, clots don't have to completely occlude that vessel. We can have partially occlusive DVTs. So this is an acute DVT that's partially occlusive. So there is some flow getting around it. So here in transverse view, and then in sagittal view, you can see flow getting around this acute clot. Transverse, again, what it looks like. And then collateralization. So again, when there's DVTs, these patients will often develop collateral veins around the thrombus vessels. So these collaterals may be located adjacent to the thrombosed vein or more distally. Typically, they're smaller and often tortuous or braided. Collateral flows are more continuous in nature. So with these collateral channels, if you were to Doppler them, you're not going to have that nice phasicity that we'd come to expect. Collateral vessels are much more difficult to compress. So just keep that in mind. Collaterals usually cannot be followed for any significant length, so they kind of come in and out. You lose them. It's kind of hard to connect them back, to the main vessels. When you really want to image collaterals, venogram is really the way to go. You get a much more detailed picture than you do with sonography. So this was showing a central venous thrombus with some collateral vessels, around around the central thrombus. Here you could see in sagittal some of those collateral vessels. There was a nice little chart, just kind of breaking down again, acute versus chronic, the differences, between acute and chronic, their effects on the vein. The chart to kind of bring that home. Here we can see again another partially occlusive thrombus within the femoral vein. So this looks like it's more chronic in nature. Again, I'm seeing like linear echogenic stranding, recanalization of the vessel. Looks like stuff's adhered to the walls there, but it's brighter, it's more echogenic. So when we're, writing up our DVT reports, it's important for us to determine or document the extent to which, the patient's vessels are thrombosed. So, when we do our preliminary report, we start, with common femoral vein. So we'd say, common femoral vein, popliteal veins are patent and compressible. And then depending on where the vein starts, maybe it's just capping DVT, then we would say, like patients posterior proximal, mid and distal posterior tibial and peroneal veins are non-compressible and do not demonstrate color Doppler flow signals compatible with acute thrombosis of the, posterior tibial and peroneal veins. Or if it's involving, common femoral, or, we'd say, right common femoral vein is non-compressible, does not demonstrate Doppler flow signals compatible with, thrombosis of the right common femoral vein. Or if it's multiple segments that are involved, we'd say right common femoral, popliteal are all non-compressible and do not demonstrate color Doppler flow signals compatible with acute DVT of the common femoral and popliteal veins, whatever segments are involved. We might talk about, residual thrombus or chronic thrombosis, if they've had a history. Instrumentation, so we know that we utilize, our linear transducer, so our high frequency linear transducer, particularly when we get into the upper extremity veins or in the superficial veins, we like to utilize as high frequency as we can go. If we have to image, say, external iliac or common iliacs or even IVC, we might have to switch to that low frequency curve transducer. Or for larger patients trying to image that subclavian, we might have to utilize the lower frequency 2 to 3 megahertz curve transducer. We want to get nice grayscale resolution, pulse wave Doppler to detect that flow, and optimize our color settings, for slow flow. Because now we're talking about venous flow. The flow is significantly slower than arterial flow. So we have to adjust our color Doppler settings accordingly. So upper extremity exam. So we include both the superficial and deep veins when we're talking about the arms. Patient preparation. So again, we want the room nice and warm, relax the muscles. We have the patient supine or even sitting, the head raised and the arm, the head raised for the arm vein imaging. We can have the bed flat if, again, we notice that some patients blood might have jugular or subclavian vein being collapsed. If we flatten the bed down or even lower the head down, that will help promote the jugular and subclavian veins from collapsing. With our technique, we're going to check for compressibility. We're going to document spontaneous and phasic flow. If necessary, we would perform augmentation or Valsalva responses. Again, our duplex for upper extremity will start with the internal jugular vein. Then we move to the subclavian vein, and documenting, compressibility, documenting flow. We're documenting, basicity with our Doppler tracings. So again, we just move through the segments: internal jugular vein, move to subclavian vein, then axillary, brachials. Some places terminate their exam with the brachials. They don't actually go into radial and ulnar. And then we also document, cephalic and basilic veins, because again, these are important superficial veins that are often accessed for intravenous lines and blood draws. So they're often the ones that are going to be poked and prodded. Again, that's part of Virchow's triad. They're subject to that intimal injury and susceptible to developing thrombosis. In our capabilities, we want to rule out to identify thrombosis in the upper extremities. We can differentiate between acute and chronic thrombosis. We can tell whether or not the thrombus is non-occlusive or occlusive. We can distinguish, between something that maybe is compressing the vessel versus an actual clot within the vessel obstructing it. We also can utilize our duplex for performing our vein mappings, like I said, for potential hemodialysis access, creating those fistulas. We can recanalize channels or evidence of collateralization. Then some of our limitations, patients' innominate vessels might not be adequately visualized, as well as subclavian due to patient body habitus, bony structures. So our jugular vein. So we've practiced imaging jugular vein here in lab. So again, jugular vein sits anterior or above, the carotid arteries. So you can see jugular vein, common carotid artery. Coming more superior, the common carotid artery bifurcates or splits into internal and external, but we still have our jugular vein. Coming more inferior, we can potentially visualize the external jugular vein in that image as well. It's a nice sonographic image here. So the one on this side, show transverse image, internal jugular vein, common carotid artery, nice echo-free vessel versus a thrombosed jugular vein. So you can see once it's thrombosed like that, again, dilates. We see the intraluminal echoes. I'm sure if I was to put color on here, there'd be no flow, or maybe a little bit of flow getting through here, possibly. I'm sure this is almost completely non-compressible. So subclavian scanning. Again, if you want to get that proximal subclavian where it connects with the brachiocephalic, we have to come supraclavicular or above the clavicle. So again, my trick, follow that jugular vein down, see where the subclavian and jugular vein come together, try and find the origin where it dumps into the brachiocephalic. When we image subclavian, when we come infraclavicular below the clavicle, coming a little further out towards that shoulder. Again, when we're in a transverse orientation to the vessels, we can potentially see that cephalic vein connecting in. Here's just showing a couple of different approaches, supraclavicular versus infraclavicular. Me personally, I like that infraclavicular approach. So you're kind of underneath the clavicle, kind of angling up back at it. So it's almost like a little scooping technique. So images showing subclavian vein on ultrasound. So a nice sagittal view, subclavian vein, and then short axis. So this is where we would do that sniff and try and compress it. That's required of the Christiana Vascular Lab. So our Doppler waveforms. So we talked about, those central veins in the upper extremity having a good degree of pulsatility to them. So these, again, normal subclavian Doppler signals. This is what we expect, basicity and pulsatility to them. This was with sniff augmentation. So we did that here in the lab. Again, if this is normal. This is what we expect to see. So when you're doing your DVT study, so even though I didn't have you guys do it here, every upper extremity DVT study has to be concluded or finished up with the contralateral subclavian vein being Dopplered. We need to show a Doppler tracing of that contralateral subclavian vein to demonstrate that there's similar phasicity and pulsatility to those two vessels. Because again, we could use that to potentially say, hey, you know, even though there's flow in it, the Doppler signals are vastly different. This one, you know, is very pulsatile on the asymptomatic side. On the symptomatic side, it looks very continuous. It's much less pulsatility, much less phasicity. Something might be blocking or obstructing or compressing that vessel central that we're not seeing. You know, we need to investigate further. The doctors need to order another exam, or we need to take a closer look and try and image that brachiocephalic if possible. This was just showing subclavian vein. So we can have definite limitations due to the clavicle and the sound waves not being able to penetrate through the patient's clavicle, creating the shadowing and dropout. Then moving into the axillary here. So with axillary vein, we could see here, also potentially we might see the junction of the axillary with the basilic there. So again, we could come right in the patient's axilla. We can also take a more anterior approach. So sometimes you can come from the anterior chest wall and kind of angle, you know, instead of coming right in the armpit, you can come a little more anterior, angle back at it. Some patients have a good window there as well. With that anterior approach typically makes it a lot more difficult to do your compression pictures, but you might get a more clearer grayscale. Depends on the patient again. Moving down the arm, you know, you have your A represents mid upper arm, B being in the axilla, C is further down towards the antecubital fossa. So we're just showing some different probe positions again for imaging axillary brachials and then getting into radial and ulnar. So with axillary, again, it should just be one artery, one vein when we're imaging the axillary. Once we move down into the upper arm now, we see our presentation of our brachial artery with the two paired brachial veins. So again, a vein on either side. And then the basilic, you know, being its best friend there, kind of hanging out by itself with no associated artery. As we move further down the arm, you know, that basilic vein, the superficial one, the basilic vein starts to migrate slowly away from the brachials. And we see just the brachials again. And then once we move down into the forearm, we have our paired radial and ulnar. As you move further down the arm, they start to move away from each other, and we can see them individually there. Again, brachials are paired, one artery, two veins. Radial and ulnar are paired, one artery and two veins. So this was just showing some nice pictures here for axillary artery and vein. So you can see nice patent, echo-free artery and vein. Feels nice, completely with color. Here we can see axillary branching into your brachial and basilic. So here we can see a nice picture. So I want you guys to be able to recognize, you know, on your exams, on your quizzes, brachial artery, brachial vein, basilic vein by itself. So when you see that artery and the two veins, you know that's the brachials, and then off to the side is going to be the basilic by itself. So here we see brachial and basilic all together with and without compression. So with compression, we're left with just the brachial artery. The two veins compress, the basilic vein compresses. So again, can you identify these vessels? So again, I want you guys to be able to point out which is the artery, which is the veins, the deep veins, the superficial vein. And our sagittal view of our brachial veins. So they look very similar to our calf vessels when we're in sagittal. So you can see that vein, artery vein, be impaired. Again, here are the brachial veins at the antecubital fossa here. So this is getting close. Now we can see that median cubital vein starting to come in there. The radial and ulnar bifurcation. So just keep in mind when we're talking radial and ulnar that the brachial artery and veins actually extend past the antecubital fossa, past the elbow, into that proximal forearm. So the radial and ulnar don't actually come off until, that proximal forearm. So there is a segment in that forearm where it's still brachial. So just keep that in mind. So here you can see they're in close proximity to us when we're very proximal in that forearm. And then as we move further down, they start to move further away from each other. As we move further down the arm, so we could see here, we're on the thumb side or the lateral side where we can see the radial artery, the radial artery there, and then the veins on either side. And then with that, we could see a superficial vein with no corresponding artery, and that's going to be our cephalic vein if we're on that lateral side. On the medial side, we would see the ulnar. So here's just a series of images, sonographic images. So jugular vein moving to subclavian, axillary, brachials with the basilic, brachials by itself, then moving down your radial and ulnar in your forearm. So the cephalic vein, one of the superficial veins. So we could potentially see it connecting to the patient subclavian vein. So it's a good practice if the patient does have a thrombosed cephalic vein in their upper arm and it's thrombosed as far up as you could see it in that upper arm. See if you can try and find the origin, because if that cephalic vein is thrombosed all the way through to the junction and is now extending into that subclavian vein, this patient now has a DVT. So as opposed to just being treated for, superficial thrombophlebitis, we now have to change course of treatment and be treating them as they have an acute DVT, because then that could potentially break off and easily embolize and wind up with a nice PE. So cephalic vein, when we're imaging the upper arm, it was in that little tissue fossa that created almost like that eye of Cleopatra. So here we could see it connecting the origin of it to the subclavian vein here. So that's a nice origin picture. And then here we could see that distinctive prominent cephalic vein. Cephalic veins can vary quite significantly in size, as some of you have encountered. Some of you have nice, large, juicy cephalic veins, very easy to visualize. Others of you have very small cephalic veins. And then basilic vein. So again, basilic vein, we can visualize it in the upper arm. We can see there in proximity to the brachials. We follow that basilic vein down the medial portion of the upper arm. So again, when we're imaging and that patient's arm is out, up here on that inner arm is the brachials. I come down a little bit into that that upper arm, and that's where usually the basilic vein resides, and we can follow it down, that inner portion of the upper arm and down the medial aspect of that forearm. So then it goes all the way down the arm towards the wrist. Well, nice sonographic picture in our upper arm demonstrating the brachial artery with the two veins and the basilic vein by itself off to the side, more medial. Just keep in mind there are lots of different anatomical variations when we're talking about the superficial veins and the median cubital vein and how they connect at the antecubital fossa. So again, not every person's the same. In this case, we have a dominant, basilic vein coming into that median cubital vein. And then the cephalic vein in the upper arm is very atretic, it's very small in caliber. So there's probably very minimal flow getting through this. So this might be some of you guys that had a hard time seeing the cephalic vein in the upper arm. And they had a very dominant basilic, larger median cubital. And then that gave rise to a larger cephalic vein going down the forearm. Again, all different types of anatomical presentations. So here we can actually see what looks like two cephalic veins in that upper arm. Here, this position for the median cubital vein isn't a single median cubital vein. It's like branches into one, branches into another. They kind of come together. This looks like the interosseous vein coming down. We're just showing some more diagrams for upper extremity vessels, and what they look like on ultrasound and related to some of their tissues. Again, interpretation. So in normal upper extremity venous findings, so the veins should be widely patent. The walls should collapse completely, so should be able to compress them down fully. Some veins are covered by bones, so then we do get some limitations to that. Other structures may not be completely compressible. We could potentially see valves in these veins, so again, that's normal finding. The Doppler and color flow patterns should demonstrate spontaneous flow with normal phasic changes. Again, there's pulsatility to those more proximal upper extremity veins. So abnormal findings would be obviously the presence of thrombus or echogenic material within that vessel itself, within the lumen of the vessel. Flow patterns that demonstrate continuous flow or potentially elevated velocities. Again, if they're elevated velocities, then we start to worry about maybe fistula formation or connections, arteriovenous fistula patterns. Color flow patterns may be absent if the vessel is completely occluded or thrombosed. Color indicates recanalization of thrombus, recanalization of vessels where there's been previous thrombus. So we can again use that color flow to help us evaluate for thrombus. And then one of the last things I just want to kind of mention when we're talking about upper extremity scanning are nerves. So particularly when we're in the upper arm, we have a brachial nerve that exists up here. And that brachial nerve I've seen a lot of times be mistaken for an occluded or thrombosed vessel just to kind of where it sits. So here we can see this is the brachial nerve in the upper arm. We see the brachial artery and veins over here patent. There's good color filling. Basilic vein patent, good color filling, no evidence of clot. And we see the structure over here. In transverse, it looks like a clot. It looks like a vessel. And you can kind of follow it up and down because it runs up and down that upper arm. But this brachial nerve will not connect back into any of these others. So that's the nice thing, like I said, about vascular, about vessels. All roads lead to home. So these vessels will all eventually kind of come together. They'll connect to other vessels. It's streams of a river coming together and they'll all flow together. So these vessels will eventually all come together. As we follow these up, they're going to come together, form the axillary. Whereas this guy will just kind of disappear. In sagittal, you can get a kind of a better appreciation of what it actually is. So nerves, again, they're very echogenic, the insides of them. When we turn in sagittal, you'll see linear lines all lining up across this vessel like this. There's not going to be any flow to it. So this just doesn't look like, a thrombosed vessel. Like it's not a chronically thrombosed vessel like this. It doesn't look. Nerves have a very, unique appearance where they have these linear striations go all the way across the vessel like that. Again, it's unchanged throughout the course of the vessel, so it's going to look the same through its entirety, But just again, keep that in mind. I kind of just want to show this to you because I definitely have seen plenty of patients come into the hospital like, oh, I went to an outpatient imaging site, they said I had a clot in my arm. I scan them. I'm like, no, they were probably just imaging this brachial nerve. Your vessels are fine. You don't have a DVT, So that's nerves. Lower extremity, we will start next week. We'll pick up from here, 106. So that was good. Got through halfway. Thank you for your patience and understanding. And I will post this to D2L now. And have a good weekend. I will see you all next week. Thank you.